Hello, my name is Zachariah. This is my report on rhabdomyolysis. Rhabdomyolysis is the breakdown of muscle fibers, specifically of the sarcolemma of skeletal muscle, resulting in release of muscle fiber contents, myoglobin, into the bloodstream. The sarcolemma is the cell membrane of a muscle cell. The membrane is designed to receive and conduct stimuli. It is a barrier between the internal and external myofibers environments. When the force exceeds the structural ability to resist the stress is what causes the disruption of sarcomeres. Strenuous force is what causes stress upon individual sarcomeres, and sarcolemma damage contributes to distribution of myofiber protein structures. Why worry about rhabdomyolysis? When muscle is damaged, a protein pigment called myoglobin is released into the bloodstream and filtered out of the body by the kidneys. The broken down myoglobin may block the structures of the kidneys, causing death of tubular epithelial cells that form the renal tubules of the kidney or kidney failure. Then muscle tissue may cause a large amount of fluid to move from the blood into the muscle, leading to hypovolemic shock, causing reduced blood flow to the kidneys. This is kind of a picture of the process. It's a picture of muscle breaking down, then the myoglobin being released into the bloodstream and filtering through the kidneys. When the myoglobin blocks structures of the kidneys, this is when the damage begins, such as oxidative stress, inflammatory response, endothelial dysfunction, vasoconstriction. The causes of rhabdo may result from a large variety of diseases, trauma, or toxic insults to skeletal muscle. Risk factors include alcoholism, crush injuries, ischemia or necrosis of muscles, severe exertion, use or overdose of drugs, metabolic myelopathies, temperature related. For this presentation, I'll be focusing on severe exertion through physical fitness. Exertional rhabdomyolysis is exercises beyond physical limits. ATP demand outweighs supply, resulting in cellular membrane breakdown. Any insult that damages the ion channels through direct myocyte injury or reduces the availability of ATP for energy will cause disruption in proper balance of intracellular electrocyte concentrations. Causes of cellular destruction of rhabdo. Direct injury to cell membrane, such as crushing, tearing, burning, severe electrolyte disturbance, disrupting sodium-potassium pump. During normal muscle physiology at rest, ion channels, including sodium-potassium pumps and sodium-calcium exchangers located on the plasma membrane, sarcolemma, maintain low intracellular sodium and calcium concentrations and high potassium concentrations within muscle fiber. Muscle depolarization results in an influx of calcium from the reserves stored in the sarcoplasmic reticulum to cytoplasm, causing the muscle cells to contract through actin myosin cross-linking. All of these processes are dependent on the availability of sufficient energy in the form of adipose triphosphate, ATP. Therefore, any insult that damages the ion channels through the direct myocyte injury or reduces the availability of ATP or energy will cause a disruption in the proper balance of intracellular electrocyte concentrations. Muscle cell hypoxia leading to depletion of ATP. When a muscle injury or ATP depletion occurs, the result is an excessive intracellular influx of sodium and calcium. An increase in intracellular sodium draws water into the cell and disrupts the integrity of intracellular space. The prolonged presence of high calcium levels intracellular leads to sustained myofibril contraction that further depletes ATP. Factors in development of exertional rhabdomyolysis: fitness level, intensity of exercise, eccentric exercise, concentric exercise, ambient temperature, and hydration level. One of the major challenges of diagnosing external rhabdo is the fact that serum CK levels will naturally rise after strenuous exercise in almost all normal humans, potentially up to 10 times higher limit of normal. Serum CK is creatine kinase and is an intracellular enzyme involved in energy production, phosphate release from ATP. It is released into the extracellular space in muscle damage. Concentric exercise occurs when the muscle fibers shorten. The concentric portion of a movement works against the force of gravity. Examples are pushing up in a bench press, standing up in a back squat, sitting up in a sit-up. Eccentric exercises involve increasing muscle length. You're working with the force of gravity. These are known to help build muscle mass and increase strength. The majority of muscle damage occurs during eccentric training. Examples of this are lowering barbell to chest in the bench press, lowering onto the bottom of a sit-up. This is a picture of normal muscle biopsy and rhabdomyolysis. Muscle damage is loss of muscle function caused by disruption of muscle structures involved in producing and transmitting force. Known events associated with muscle damage or distribution of sarcomeres, distribution of force transmitting sarcomere structures, damage to the cell membrane, impaired excitation, concentration, contraction, coupling, loss of force production. Major plays in exercise induce muscle damage or subsequent inflammation on neutrophils, monocytes, and macrophages. So 10. Cellular pathophysiology, influx of extracellular contents such as sodium, water, chloride, calcium, and efflux from damaged muscle cells, potassium, phosphate, lactic acid, and other organic acids, purines, myoglobin, thromboplastin, creatine kinase. The graph showing the chemical composition and the amount of cellular fluids coming in and out during cellular destruction. Picture showing the pathophysiology of rhabdo. Muscle trauma that pretty much the sum of it is muscle trauma that compresses tissue, causes ischemia and necrosis. The sacroilium is disrupted and intracellular muscle cell components are released. Cell destruction occurs due to cell membrane injury, muscle cell hypoxia, depletion of energy sources, and electrolyte imbalance affecting the sodium potassium pump. Ensuring local edema further increases component. Soil fraction release of myoglobin from the neuron into circulation. Damage, acute tubular necrosis, acute renal failure, hyperkalemia, cardiac arrest, disseminated intravascular coagulation, and compartment syndrome. Myocyte injury, hours of ischemia. 1 hour is okay, you're not really looking at any permanent damage. 3 hours is about irreversible anatomic and functional changes. And around 5 hours, you have muscle necrosis. Symptoms of rhabdo: muscle tenderness, weakness of the affected muscles, general weakness, muscle stiffness or aching, muscle cramps, abnormal urine color, fatigue, nausea, and vomiting, thirst, or headache. This is a picture of rhabdomyolysis. How do you test for rhabdomyolysis? Examination reveals tender or damaged skeletal muscles. Creatine phosphate levels are very high. Serum myoglobin test is positive. Serum potassium may be very high. Your analysis may reveal protein and be positive for hemoglobin without evidence of red blood cells or microscopic examination. Your myoglobin test is positive. Creatine is a product of metabolized creatine. If kidney function is abnormal, creatine levels will increase in the blood. Treatment for rhabdomyolysis or early aggressive fluids. Hydration may prevent complications by rapidly removing myoglobin out of the kidneys. Administration of isotonic crystalloids, fluids, norsaline, and lactated ringers. Medicines that may be prescribed, including diuretics and sodium bicarbonate. Facts about rhabdomyolysis. Rhabdomyolysis accounts for an estimated 8 to 15% of cases of acute renal failure. The overall mortality rate for the patient with rhabdomyolysis is approximately 5%. Rhabdomyolysis is more common in males than females and may occur in infants, toddlers, and adolescents. Here are my references.